Okay, in this session we're going to cover the use of X-rays in human imaging. What we're going to cover is the principles of X-rays, and last week we covered both particular radiation and X-rays, basically the electromagnetic spectrum. So we're going to cover very briefly these again, but you did see them last week. A little bit on dose measurement, and then we're going to get on to X-ray image production and look at some example images, and in particular look at some images associated with COVID-19 and how X-rays are fundamental to helping to diagnose patients in the absence of molecular tests for the virus. So as we covered last week in the radiotherapy lecture, radiation is emission of some sort of energy from a body, is the description there, but from something, and we're dealing with individual atoms here. As we covered last week, they can be particles or they can be electromagnetic waves. Now, the particles are things like alpha particles, beta particles, so helium nuclei, electrons, positrons, whereas electromagnetic radiation can be everything on the electromagnetic spectrum, but we are primarily here dealing with things that are shorter in wavelength than ultraviolet. So we're dealing with low energy X-rays, high energy X-rays, and into the gamma. And these electromagnetic waves can be ionizing or non-ionizing, and we covered that last week, but I'll briefly mention that again. So just a quick reminder of alpha particles, although we're not talking about those from an X-ray point of view, it's just as a quick recap. So atoms can emit alpha particles, which are two neutrons and two protons, call them a helium nucleus, or they can emit beta particles, which is either an electron or a positron, which is effectively a positive electron. And we covered both of these extensively in the radiotherapy lecture, so if you're not familiar with these, have a look back at the radiotherapy lecture. So electromagnetic radiation is not technically particles, they are waves or packets of energy that we call photons, and these behave in exactly the same way as light does, so travel in straight lines, and they travel at the speed of light, and they have variable wavelength and frequency. So if you've got a high frequency, you've got a shorter wavelength, and those are higher energy and more dangerous, and when you get beyond a certain point they become high enough energy to be ionizing. So this little diagram shows us the electromagnetic wave spectrum. We're not really worried about the very low energy things like radio, microwaves, that type of thing. Into the visible wavelength spectrum here, longer than that you've got infrared, shorter than that you've got ultraviolet, and then beyond ultraviolet we start to enter the X-ray region. You can have low energy X-rays, high energy X-rays, and then we move into the gamma rays. And I explained this to some extent last week when we talked about radiotherapy, and it just highlights the difference between ionizing and non-ionizing radiation. A non-ionizing radiation, you will get a photon of energy coming into an atom, exciting an electron to a high energy state, which will fall back down to a lower energy state, and that would be excitation and non-ionizing. Whereas if that photon is of higher energy, it will come in, excite an electron to the point that it actually leaves the atom, leaves this atom charged, and there'll be a charged electron leaving that atom. Both this charged atom here, and it could be an atom on its own, or it could be something like a hydroxyl radical or hydroxyl ion. This thing and the electron can both go on and react with, the most thing we're concerned about is reacting with DNA within the cell and cause DNA damage, and that's the principle of radiotherapy that we covered last time, but we need to consider this from a safety point of view when we're dealing with human imaging, because all of the X-rays which are fired at patients have the capacity to cause ionizing damage to the cell. And the main concern with radiation damage is the induction of cancer. So if radiation is received by a normal cell, there will be DNA damage. That damage can very effectively be repaired by an error-free repair pathway. I'm not going into great detail on this, but basically the cell spots that there's damage. It could be something like a single-strand DNA break. That can cause a replication fork to collapse, and that can be then pieced back together without making any mistakes whatsoever if it's just a single strand phosphodiester break. And then this cell will, once it's repaired the damage, undergo error-free repair. It will come back to be a normal cell. If the DNA damage is more extensive, particularly if it's a double strand break or if it's resulted in the loss of nucleotides, that can often result in error-prone repair. So the broken DNA ends are sort of just stuck back together in a slightly haphazard manner, and the cell carries on, but it may well have DNA damage. There may well be crucial tumour suppressor genes that have been inactivated, and that can drive cancer formation. If that DNA damage is actually spotted, the cell should undergo apoptosis, which is programmed cell death, and whilst it undergoes the process of trying to repair its DNA, the cell should also undergo cell cycle arrest. And that will just stop a damaged cell from dividing and turning into a potentially transformed cell, which leads on to a cancer cell. Now, when we're discussing radiation, inevitably we get onto the conversation of dose, and there are lots of ways of describing dose, and I'm just going to go through the three main ones that are relevant, and that's particularly how much energy has been deposited within, let's say, a patient. So an absorbed dose is one way of describing dose, so it's the total amount of energy deposited per kilogram by the radiation. But we then have an equivalent dose, because not all radiation is equal. Alpha particles are particularly DNA damaging, so 1 unit of alpha particle energy causes 20 times more damage than an equivalent amount of energy from gamma rays or beta. So we have an equivalent dose, and then we also have an effective dose. And the effective dose relates to how each individual tissue responds to that radiation and how much damage is caused. And some tissues are particularly sensitive, and some are relatively resistant to DNA damage. So, for example, the gonads and rapidly proliferating epithelial of the gastrointestinal tract are very sensitive, whereas skin and bone are pretty resistant. So the first one is the absorbed dose, just a little bit more detail on that. And this is how much energy is actually received by the patient. So we measure this in joules per kilogram of tissue, and we know how well X-rays are absorbed by tissues depending on what their energy is, and we can convert that into joules per kilogram. So if we know what proportion of those X-rays are absorbed by the body, we can make those sorts of calculations, and the unit that we actually end up with is the unit of absorbed dose, which is the grey. And we talked about this extensively last week when we looked at radiotherapy regimes, where we'd be maybe giving someone 60 grays of radiation, maybe fractionated over 10 or more doses. And because this is just a measure of energy, it's not really affected by the type of radiation. 1 gray of alpha is still 1 joule per kilogram, whether it's alpha or whether it's gamma. It's just that the amount of damage it causes differs, but we would say that would be 1 gray of energy. And this is where we start to get that variation when we look at the equivalent dose. So this is where the different types of ionizing radiation having different effects on the body. So we have a weighting factor for X and gamma rays and beta, and the weighting factor is 1, whereas for alpha the weighting factor is 20, and this is just to reflect the fact that alphas are 20 times more DNA damaging. So 1 gray of alpha will give 20 times more DNA damage than 1 gray of X-rays. But as we found out last week in the radiotherapy lecture, although we do use alpha-emitting radionuclides in radiotherapy, these tend to be conjugated to antibodies and targeted to the tumour, and same true for beta emitters. We maybe have, if you look back on those lectures, you'll see we had iodine, radioactive iodine impregnated particles, what we call brachytherapy, implanted into organs like the prostate. And you'll probably remember the plaque brachytherapy for treating eye tumours. So these are where the betas and the alphas are within the body and emitting radiation out to kill the cells that are nearby. Whereas for X-ray, gamma ray radiotherapy, we are firing those photons from outside the body. And when we talk about equivalent dose, we convert the greys, multiply it by the weighting factor, and we end up with another unit. You don't really need to go into any details about the calculations here, but just be aware that those the equivalent dose is measured in sieverts. When we're looking at doses for humans, we're dealing with microsieverts or millisieverts. And we'll look at a table of different procedures that can be done and look at how many micro or millisieverts that will give you in terms of from imaging later on in the session. But this is where it's important. If you've been exposed to, 1 gray of alpha, then this is where it gets multiplied up by 20. So it will cause 20 times more damage. And then we also have an effective dose, and this is to reflect the fact that different tissues respond differently to radiation in different ways. So the gonads particularly will undergo lots of DNA damage. If you think about the testes, very rapidly producing lots of sperm cells. Very rapidly dividing cells are most sensitive to radiation damage, and that's why we use it in radiotherapy for cancers, is that we want the most rapidly dividing cells to undergo programmed cell death or apoptosis. But the gonads are dividing, we have cells in there dividing incredibly quickly, so therefore they will respond with lots of programmed cell death in response to radiation, much quicker than something like skin. Although skin does regenerate very quickly, it is very, there are cells in your skin which are dividing very quickly, but there are also lots of cells in your skin which are just sat there doing a job, what we call fully differentiated. So those cells are very insensitive to radiation. You see there the bone marrow is very sensitive. Within your bone marrow you've got millions of cells created every hour, immune cells and cells that are going to produce your red blood cells. Those are very sensitive because they're dividing so fast, and as are the lining of your gastrointestinal tract, colon, stomach. Those are also very sensitive to radiation. And then other tissues, less so. So there's a limit to how much radiation somebody should receive in a year. And the general public is 1 millisieverts. If you are employing the radioactive industries, it might be 20 millisieverts. Employees working with radiation as part of their job, such as radiotherapy, maybe dentists who are doing lots of x-rays, we have a higher acceptable level of radiation exposure than the general public. This is 6 millisieverts. These are all under review, constantly under review. And when we look at where we get exposed to, why we get exposed to radiation, it comes from lots of different places. So for most people, occupational exposure is a tiny fraction of it, whereas if you're working in the radiation industry, it's going to be a much more major part of it. Medical x-rays and imaging accounts for about 14% of the radiation that we receive on average. Obviously for some people that's significantly higher, some people it's going to be very, very low. About half of it comes from the breakdown of radioactive elements and the formation of radon gas coming up from the ground. And if you live out in the high peaks in Derbyshire, you'll be exposed to much higher levels of radon gas than if you live in Sheffield, for example. So this does vary depending on where you live, and that's why some people out in, particularly in Derbyshire, where there's lead deposits and you get lots of uranium breakdown and formation of lead and also radon gas, they have radon detectors in their cellars to let them know when there's a build-up of radon gas in their cellar. We also get cosmic rays from outer space, and just the materials that the buildings are made of are emitting very small amounts of radiation, just very, very low levels. So this slide just shows the different doses of radiation exposure measured in millisieverts, and what effects it will have upon the patient. So if you receive 10,000 millisieverts, that will be fatal within weeks. And we're talking about doses. I mentioned last week about the Russian dissident Litvinenko, who was poisoned with polonium in a London cafe. He received a fatal dose of polonium that was in the order of this sort of dose, and he died after about 6 or 8 weeks after receiving that dose. If anyone's watched that new documentary film about Chernobyl, you'll have seen workers working around the site of the Chernobyl disaster dying about a few weeks to a month after the event. They're exposed to about 6,000 millisieverts. So radiation sickness comes on at about 1,000 millisieverts, but doesn't induce sort of immediate or short-term death, but a good chance that it will induce cancers much later on. 100 millisieverts is a recommended limit for radiation workers every 5 years. So that was on the previous slide, showing 20 millisieverts per year. And all radiation workers have radiation badges that detect the amount of radiation absorbed or exposed to. So when radiation workers are working in a place like Sellafield, they're constantly being monitored about how much radiation they're being exposed to. And that's also true for anyone working with radiation in labs. In the old days when I worked on phosphorus-32 labelled nucleotides for DNA sequencing, I would always have to have a small radiation badge to make sure that I wasn't exposed, and that's true for any research lab. If you have to have a full body CT scan, we're dealing with about 10 millisieverts. Now this is important because I'll be talking about CT scans later, particularly with the in the diagnosis of coronavirus and how it affects the lungs. So 10 millisieverts seems like quite a lot, sort of 10 times your annual dose of background radiation. However, we are remarkably good at repairing radiation-induced DNA damage. If you fly backwards and forwards annually as on an airline crew, you're receiving in a year about the same amount of radiation from enhanced cosmic rays in particular as if you had a full body CT scan. And we're getting down to the much lower levels of radiation. The typical mammogram, which is X-ray based, and I'll show you some images of that later, 0.4 millisieverts. A simple chest X-ray 0.1, and the dental X-ray 0.01. So these two are really very, very minimal in terms of accumulating your radiation dose over the course of your life or within a particular year. And on this side it shows you the lifetime estimated risk of dying from cancer from a single exposure to all of these different medical treatments. So a CT scan of the chest is equivalent to a few years of natural background radiation, and the best estimates is that increases your chance of cancer to sort of 1 in 10,000 to 1 in 1,000. Bearing in mind that 1 in 5 people develop cancer, this is slightly pushing up your risk by a tiny amount. And mammograms as well, they do push up the overall risk of cancer, in particular breast cancer, but by a very, very small amount. And that's partly why the breast screening program starts much later on in life, and people are limited to how many mammograms they are exposed to over a certain period of time. The amount that they're exposed to is calculated to have the maximal benefit of detecting the maximal number of breast cancers whilst exposing the minimal number of people to a new radiation-induced cancer. So the frequency and the time of onset of mammograms are calculated in such a way that it is an overall benefit to the population. So what we're going to cover now is the principles of how radiographic images are produced and how the X-rays interact with tissue to create these images, which are often obviously very bright white for bone, greyish for soft tissues, and the background tends to be very black. So the X-rays are produced by a cathode ray, So we have a heated element here that emits high energy electrons. They're accelerated at very high speed into a target on an anode, and as these electrons hit this target, X-rays are produced, and they sort of emit down this way based on the angle of this. And those X-rays are then directed towards the patient, and then behind the patient is an X-ray detector. So within in an X-ray, a clinical X-ray facility, there are no radioactive elements used. It is all of the X-rays are generated in this same way, and that's also true for external beam radiation that we covered last week. Whereas going back 50 or 60 years, maybe a bit further, when X-rays were first being developed for medical imaging very early in the 20th century, those X-rays that were generated from radioactive elements. So when we're doing imaging, we are exposing a patient to a beam of X-rays, many of which will penetrate and pass straight through the body, and they will be detected on a detector on the far side of the patient's tissue. Some of those X-rays will enter the body and interact with tissue and will effectively be blocked. So where you've got dense tissue, you get fewer X-rays coming out. And then we'll also get scattering of X-rays, so they're coming in at one angle, hit something, and then head off in a different direction. So previously, X-rays were clinical X-rays were done using X-ray film, and I can certainly remember the days of having dental X-rays done, and then the dental technician would wander off to the dark room, expose the film to chemicals in a dark room, and then come back with an image showing the extent of decay. That's no longer done. Everything's done now by digital radiography, where we have effectively a CCD type camera, very sensitive, that is able to detect the photons hitting the effectively a camera chip. So it's pretty much a digital camera that responds very well to X-rays hitting the chip. So we use that instead of X-ray film now. So the image that we get is dependent upon how many photons pass through and hit the detector, and the images that are generated will show if there's basically lots of X-rays passing through, we get a very black image. If we get very low energy of X-rays, as in few X-rays passing through, most of them being blocked by the tissue, we get a white image, and that's the classic X-ray that you are very much familiar with. Now these are all done as if you imagine just taking an X-ray of a patient, you just get an image of where the X-rays have been blocked, and therefore you only get one view of the patient. We can do 3D structures from a multiple 2D images. So if you imagine taking an X-ray of someone's leg, at one angle it might hide a fracture, you turn it around by 90 degrees, you might see the fracture. So often multiple X-rays are taken at multiple different angles, and I'll briefly mention X-ray based computer tomography in a moment, where we take multiple X-rays from multiple angles to create a 3D image of the patient. So this is just this classic X-ray that you'll be familiar with, where we've got bones blocking the X-rays. Bones are very dense in calcium. Calcium absorbs X-rays very well, so we get blockage of X-rays passing from the X-ray source to the detector wherever we've got thicker bone. Soft tissues, you can see here this is muscle around here, which are blocking some of those X-rays. So you've got denser tissue, where you've got either thinner tissue or less dense tissue, where the skin and the fat is there. It's a lighter shade of a different shade of grey, darker shade of grey, and then here we've got the complete background where there is nothing blocking the X-ray passage, so we get a much darker image at that point. So as you're looking at patient X-ray here, we've got you can see the vertebra shown up very nicely in white there, and the collarbone and all of the other bones you can see. Any piercings or metal clips or anything like that will show up very bright white, and sometimes you'll see if the patient's being X-rayed with a zip or something like that, they show up incredibly clearly. The lungs show up as very dark because there is lots of air in there and the air is not blocking the x-rays, so you've got a little bit of soft tissue, then you've got 6 or 8 inches or more of lung, and then you've got some more soft tissue and a bit of bone, ribs at the back. But compared to here, you've got a very, very dark chest cavity, you've got soft tissues down here, and then this bit which patients get a bit concerned at when, especially if they've had an x-ray for lung cancer, will immediately think they've got a huge tumour, but that's just the heart. So this x-ray of an ankle shows why we take x-rays at multiple different angles, because this looks completely normal, can't see anything going on at all, but you take the same ankle, turn it by 90 degrees, and you can see here there's evidence of a fracture running down there, and possibly something there. But anyway, so on this front view nothing's visible, on this side view there is something visible. So that's why they tend to take x-rays from multiple different angles if they suspect a fracture. So mammograms, one of the more common uses of x-rays, apart from fractures is the most common use of x-rays, but mammograms is very common, and we're using x-rays partly to look at the density of the tissue, because cancerous tissues will show up as more dense, but also when you start to develop tumours, you tend to get very chaotic breast ducts, and those, if you think about the structure of the function of mammary tissues, is very much of a epithelial secretory tissue, secretes proteins into those ducts. Now if those ducts become blocked due to tumour formation, you get protein accumulation in there, and that protein can calcify, and that can give little specks of calcium, which we just call calcifications, within the breast tissue, and this can highlight that we've got an abnormality going on. So that's a normal mammogram. If there's a cyst, they can often show up as very, very rounded and very sort of standing out very clearly. But more interested in these here, it's not a great high resolution image, but these little speckles are breast calcifications, and a tumour would show up as a sort of a fairly bright region. Not going into great detail on mammogram interpretations, it's highly complex, but down here I'll show you that this is a ductal carcinoma in situ. This is a pre-malignant stage of tumour formation. So as a breast lesion forms, often we get some cells which are genetically abnormal and transformed. The first stage, the last stage before it becomes a fully fledged cancer, is a ductal carcinoma in situ, which is what one of these is. You get lots of blocked ducts and you get lots of calcifications showing up, and these can also show up as little lumps within the breast tissue. But apart from that, I'm not going to go into great detail on the interpretation of mammograms. It's highly complex. This x-ray is showing the detection of a case of osteosarcoma. So osteosarcoma is a primary bone cancer. So within the bone there are cells called osteoblasts which secrete bone matrix, and those cells become transformed, overgrown, form tumours, and then you normally detect them as lumps on the bone, painful lumps, and when we x-ray them you can see that the tissue that is growing around this within this tumour is partially calcified, and you can see the outline of the tumour there extending right up here. Okay, and this slide shows a chest x-ray of a patient with COVID-19 infection, and with this particular patient they'd had a chest x-ray the year before, so we've got a nice background of what's going on, and then we've got a chest x-ray of the patient coming in with respiratory distress. And just ignore this, that's just a zip. So on the previous year there's nothing too remarkable about the lungs, don't look overly large lungs, but on this side, and highlighted within these two regions, are these opaque regions which are not present the previous year. So these opaque regions are where we've got got pneumonia going on within the lungs. And what is really useful in terms of X-rays is doing the chest X-ray and seeing these opaque regions in the lungs, identifying that these patients have got pneumonia. Now these images are of a chest CT, computed tomography using X-rays. So these images are taken by exposing patients to X-rays at multiple different angles and then computing which bits of lung were blocking the X-rays at one angle and then at another angle, then another angle, and then piecing those images together and allowing you to take a cross-section through the body to see more detail what the size of the lesions are. And one consistent characteristic that's coming up with COVID-19 patients are these hazy lesions on the periphery of the lungs, so there, around here as well, and in this case patient there and there, and those are regions where we've got very strong, obviously viral proliferation, but then a very strong immune response to that virus and increased tissue density, lots of tissue damage. Subsequently there'll be lots of tissue fibrosis and scar tissue left at these lesion sites, but the combination of the chest X-rays for a quick look and a chest CT scan are proving pretty useful in identifying these classic signs of COVID-19 induced pneumonia and helping to separate that from other forms of pneumonia. And this is another CT. Unfortunately the movie that I tried to download for this doesn't work in this browser, but if you're doing CT scanning you can also generate 3D movies of the patient and rotate the patient's lungs around and see the full extent and the full volume of all of the lesions. So this is someone with extensive lesions here, 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 and all of this here. Regions where you've got much more dense lung tissue than you would expect, and these are active regions of viral infection, and then the immune system is going in there. You've got lots of immune infiltrating there and showing much more increased tissue density. Okay, so that's it. That's the end of this session. So when it comes to what you need to know from this in terms of exams or something like that, the sorts of questions I put onto the exam are: explain the principles of X-ray production and how this is used to image patients, and I normally set that as a very open-ended question. If I do set a question like that on the exam, I would always talk about more than one example. You're not going to get full marks for just talking about detection of fractures. You want to throw in additional examples. Okay, that's it.